main challenges of gastroenterology practice in 2023, I think, revolve around the key endoscopic priorities of preventing colorectal cancer, preventing cancer in the upper GI tract, and the application of minimal invasive techniques to the precursors of gastrointestinal cancer. Post-colonoscopy colorectal cancer is the situation where a patient experiences cancer, and it can be different definitions, but normally within 3 years of having had a colonoscopy procedure. And of course, patients don't understand that. Patients do not understand how they can have a procedure which is meant to prevent them having cancer, and then they get cancer later. And people would be very surprised to know that the rates can be from upwards of 7% for post-colonoscopy colorectal cancer. And so we need providers of endoscope technology, provider of endoscopic materials, ancillary endoscopic manufacturing companies to help us to absolutely minimize that result as much as possible. And that can be achieved by great optics, great imaging, platforms which allow providers to learn what the precursors of colorectal cancer look like, devices which can enable the exposure of the maximum amount of the colonic mucosa possible, and devices which help us to detect the precursors of colorectal cancer, like adenomas, for example, artificial intelligence. So all those things can be harnessed and brought to bear on the problem of post-colonoscopy colorectal cancer. Post-endoscopy upper GI cancer, or PUGIC, is an emerging priority for us as gastroenterologists. We recognize that too many patients have developed cancer within the time frame, unacceptable time frames after having had an upper GI endoscopy. And these patients also do not understand why they are experiencing a cancer after they have had a gastroscopy, because surely that shouldn't happen, right? And we know that there is a problem with the tolerance of gastroscopy procedures, which are commonly performed under sedation, commonly performed without anesthetic, and providers can help us by significantly improving the optics or the endoscopic imaging of endoscopes, but also providing us with solutions for increasing the tolerance of gastroscopy by patients. And the final thing we need help with, I think, in gastroenterology is really bringing to bear the potential of minimally invasive endoscopic resection techniques to precursors of colorectal cancer and upper GI cancer. These, of course, need to be detected first. We already talked about that. But once they're detected, we need better tools to both enable traction of these lesions in the colon and in the upper GI tract, and tools which enable us to visualize the complete extent of these lesions in real time and potentially analyze the depth of their invasion. And potentially this involves artificial intelligence algorithms in the future.